Hi, I'm still recording from Copenhagen. I recently saw a patient who was unbelievably grateful for what I thought was a relatively minor procedure that I performed. When he'd been drilling a year ago, he had suffered an intraocular foreign body. But because it was not visible in the anterior chamber, nobody wanted to remove it. And because it was not in the posterior segment, the retinal surgeons referred the patient to me. The foreign body, as you will see, was actually in the angle and buried in PAS. And I thought not very much of this, and I thought it was relatively easy to remove. But the patient's life had been completely ruined for the last year. He was not allowed to work. He was told he should never have an MRI. And he'd been told by ophthalmologists that he'd seen before that was too complicated to remove. Have a look at the video and see what you think. I was somewhat surprised.
Hi. This patient suffered a penetrating injury when drilling almost a year ago. The patient was advised to stay off work and never to have an MRI because of the possibility of an intraocular foreign body, which had not clearly been identified until referral to a vitreoretinal surgical colleague and a UBM that revealed this. There was no clearly identifiable entry wound, although there was a focal area of something inferiorly on gonioscopy that looked initially like PAS. The position of this was consistent with the UBM position of the foreign body. Intraoperatively, I'm using the TVG lens to stabilize the globe. I'm now opening the angle around the suspicious area with cohesive viscoelastic. Using the micrograspers, it became clear that the PAS is actually the foreign body itself encased in fibrous tissue. Because it is encased in fibrous tissue, the foreign body is more difficult to shift than anticipated. But eventually it is dislodged into the anterior chamber and removed from the eye. The removal has been more traumatic than I had hoped. I was concerned that I might have created a cyclodialysis cleft. Is this a cleft? 4 days after surgery, the IOP is normal and there's no sign of a cleft or even of any significant surgical trauma. 1 month after surgery, the IOP is 12 millimeters of mercury and the visual acuity is 6.5. And the angle appearance is almost normal.
So you see, this was a relatively simple thing to remove, perhaps not as elegantly as I might have done it, but there have been no lasting sequelae. The patient can go back to work, which he had not previously been allowed to do. He can have an MRI, which he would, if he needs one, which he was told he could not have. I hope you find this interesting. Thank you very much for watching.